For Dr. Francia, you've mentioned earlier that hydration plays a key role in the treatment for tumor lysis syndrome as well as with hypercalcemia of malignancy. And you mentioned that crystalloids should be used, but could we also use colloids like albumin or other fluids like hydroxyethyl starch or gelafusine for hydration? Well, because for post-cardiac patients, not really recommended to use, especially for sepsis or in C-shock, these fluids, but could we use it for the tumor lysis syndrome for hydration, especially in patients with shock?
Well, normally plain NSS is what we use, but again, depending on the situation, of course, we have to adjust. But normally plain NSS, we just adjust the running rate depending on the ejection fraction, etc.
Yeah.
But I think that's for us cornerstone. And of course, if it's a really complicated case, I think better to call in your favorite nephrologist.
Ah, okay. To help with the hydration, right, po, doctor?
Right, yes. Especially pag a lot of comorbidities, which is usually our patients, no, they have multiple comorbidities.
Yeah. For both doctors, but doctor, because there's one question only posted for Dr. Cabral, but I think it's also a good question for Dr. Francia. How do we hydrate patients with ESRD? For example, ESRD with tumor lysis syndrome or ESRD with DKA and HHS. How do you recommend going about hydration? Or would you recommend dialysis for these patients?
That's the tricky part. And like I said, and as Abby said, work with your nephrologist. Because when they don't have urine output, you can't hydrate very. Yes, they dehydrated, but up to what point? No, you probably have. You would need to have a CVP, a central line, so that you can really adequately monitor hydration. If they're on dialysis already, then definitely work with your nephrologist to put them already on. To dialyze them, for example, at that point, that can also help with the sugar, because if the dialysate doesn't have glucose, that can help, lower their sugar levels down a little bit more. You can hydrate them more without fear, because they're already on dialysis or CRRT or SLED or something like that. It also gets very tricky when you have to put them on insulin. So not do insulin drips on patients on dialysis. You might end up with intractable hypoglycemia. And this has happened to us before. Patient was severely acidotic for multiple reasons. Was on dialysis and then was also in DKA. And then we just tried a little, insulin drip, and we could not correct her hypoglycemia fast enough. We had to put her on, D50 already, D10 already in her IV fluid. So just be very careful when you do that. So work with your nephrologist. No? And it's actually very rare for dialysis patients to go into DKA because it's because whatever inherent or whatever native insulin they still have, it stays in the body for a very long time. So a lot of dialysis patients, they come to you and they say, "Hey, doc, my diabetes is cured." Kasi they don't need the medicine anymore. Nag-hypoglycemia na nga sila. But unfortunately, the kidneys aren't doing very well anymore. But if they're dehydrated, they're dehydrated. You have to give fluid pa rin. But you just have to be watchful.
Dr. Francia?
So thank you. So I think even before giving treatment, we obviously review a medical history of the patient. So if the patient has ESRD, we would actually modify the protocol and say instead of 21 days, we can break it down just so the body's not overwhelmed, the cancer cells are not breaking down too much. So that's one, we would alter the protocols. And then two, again, we of course work with our nephrologist, and it rarely happens. Again, I've never seen an ESRD patient undergo tumor
Oh,
syndrome, mainly because most of the oncologists will really alter the protocol altogether, because you have a very high risk patient to undergo tumor lysis because the baseline renal function is already altered. So again, hydration, I think we would still do, but we'd work with your favorite nephrologist.
nephrologist. Is SGLT2 medication best for type 2 diabetes?
Um, I wouldn't say that there's just one best medication out there.
Yeah.
No, really depends on the situation of the patient. SGLT2 inhibitors are good for any diabetic, but more for patients who have atherosclerotic cardiovascular disease, who are at very high risk for cardiovascular disease. They have coronary artery disease, and for patients with actually chronic kidney disease. We use SGLT2 inhibitors also for patients who need to lose weight, because the peeing out of the blood sugar helps also with weight loss. But I really must caution, no, don't give it to somebody who has uncontrolled diabetes, because they can really go into euglycemic DKA. So I usually would give it only to somebody who has an HbA1c maybe of 8 and below. Anything higher than that, I would rather get them controlled, or you use it in combination with insulin, no, so you don't have that increased lipolysis and the risk of bringing them into glycemic DKA. But it's a good medication. It can be used as monotherapy also. But I wouldn't say there's like one best medication. It really depends on the situation of the patient.
I think you've also answered this in one of your lectures. So how do you treat persistent severe abdominal pain due to DKA? I think one of the answers would be to look for the cause.
And it can be really just from the DKA itself. So if it doesn't resolve, then maybe there's some other intra-abdominal cause. So that's when you should start looking. Or if your DKA isn't resolving as fast as you think it should be.
Okay. So thank you, Doctor. So another question for Dr. Francia. For patients with CKD, can we give zoledronic or denosumab for hypercalcemia of malignancy?
Yeah, so it's a good drug to have because it's not renally excreted. So normally, if it's CKD, zoledronic acid would be probably contraindicated because the eGFR is probably so low. So denosumab would be the drug of choice because it's not renally excreted.
For Dr. Cabral, is the treatment for DKA and HHS presented same for adult and pedia cases?
That's a little tricky. I'm not a pediatric endocrinologist.
I was about to say that also, but yeah.
Children are not
small adults.
Yeah. So the basic tenets are still there, no? Hydration and insulin, but it's a lot more computation because we really have to consider the age and the weight of the child.
Yeah.
That's really where it comes into play, and then there are other issues also, of course, with bicarbonate and all that. But it's basically the same. No, we have to close the gap. We have to hydrate them. We have to give them insulin. And if a child goes into DKA, consider that they have type 1 diabetes. Yeah. But we do have type 2 diabetes kids now, no, because of the
diet,
overweight and obesity, unfortunately.
Yeah. So thank you very much for Drs. Cabral and Dr. Francia for answering the questions presented. So I think some answers might be already answered by your lecturers already. So I haven't read them anymore. So again, thank you everyone. Thank you, doctors, for your lectures. Thank you everyone who attended the ICU forum today.